I joined the National AIDS Control Organization in 1997, I was additional secretary in the ministry and also director of the NACO. I looked at the AIDS situation, and then it was pretty dismal. The entire situation was pretty dismal because of two reasons. One is the epidemic was moving at a fast pace. Lots of deaths were getting reported. There is no cure available, no prevention available. And within the government itself, the commitment to continue that program was not very clearly visible to me. Because after the first 5 years of worldwide financing, there was almost a thinking that I think the NACO should get wound up and then it should go back to the Director of Health Services. That was the thinking. So I rather was taken aback. Why then in that case, why was it put there? So I went around and found that if government has come out of that particular program at the point, things would have been worse. And all this has happened because we were living in a state of denial. By denial, I mean the government never accepted until that point of time. That is a big problem for our country. At the political level, also in international fora, we have been saying that look, we are a moralistic society, and it's not a big problem for us. There will be occasionally some cases because people are coming from outside. It's essentially a foreigner's disease, something like that. So it was not given, and the number of cases reported were also about 80 to 90,000 per year, which is a small number in a population of more than 100 crores. So they never gave too much of importance. Then I could see that when you are looking at an epidemic, which is known for not just the mortality but also the deep stigma and attached to that because of the nature of the behavior, etc. The reported cases can never be the actual number. So we need to generate evidence to convince the political leadership that what exactly is the size of the problem. So we went around and did what is called a sentinel surveillance in the country. It was started before me, but it was being conducted in a very haphazard manner. All the states were not on board. So it took me about a year of effort to bring all the states on the common platform, have common protocol for collecting samples, analysis, etc. And ultimately, we did a sentinel survey for 1 month. That is actually taking 250 consecutive samples in the case of the high-risk behavior people, that is sex workers and homosexuals, etc. And from the general population, about 400 samples. You have to take consecutive samples. And all the states have to do at the same point of time. We could accomplish it. So when the data was brought in and collected, and then we brought some experts, some epidemiologists to make a projection, we found actually the number could have been as high as 3 million. So where is 90,000? There was 3 million. So this is the type of data we were faced with. So how do we bring it to the political leadership? So that's why I think the data itself would not have made the change. But when we took it to the political leadership, luckily we had a Prime Minister who was a statesman, who was not just a political leader. Late Atal Bihari Vajpayee was the Prime Minister. So he gave us time and then we presented the data to him. He paused for a moment and he said, yes, it's a serious problem. I think we must definitely talk about it in public. And that's exactly what we wanted. So we prepared a brief for him, that giving all the points. So he chose a particular occasion where a number of parliamentarians were present. It was World AIDS Day on the 1st of December. He made a speech. There he said all the right things. You know, we were all surprised that he was so forthright and so clear in what he wanted to say. It's a big problem and we were sitting in a state of denial. We must accept it. We must sort of put a huge program, and also we must educate our children about sexuality. I mean, all those right messages were coming through his speech. So I think that was the moment is like a game changer for us. So it came not just because we are presenting certain evidence, because we all wanted him to be there, but because the political message which came from him. The next thing that we did was, how do we take it to the states? Where it was still a central program. When only the National AIDS Control Program was giving some money to the states and they are spending. At the state level, there is no ownership. So we thought, unless we have a different model of governance at the state level, this money will not be used. So when we analyzed, we found of all the states, it is only Tamil Nadu which was using the entire money given to them. They were also asking for more. So we found, how did Tamil Nadu do this? How could the other states not do it? Tamil Nadu followed a model of having an autonomous state AIDS control society. It was registered as a society under the Society Registration Act, and then the health secretary was made the chair, and they have chosen an IAS officer as the project director of the society, and then brought in civil society representatives and everybody, and they formed it, and they opened a bank account. So money used to directly flow into the bank account, not to the treasury, not to the finance department. So they could spend the money. So we said, why not we use this as a model? Because this is the right thing to do. So we put it in the project document that all the states should have this sort of autonomous AIDS control societies. So that was accepted, and all of them, I think within about 6 months' time, we could assemble a project management team, which had the Tamil Nadu person who was the project director, and also a couple of others. The director of health services in Maharashtra was also there. So this team went around all the states, and they started the state AIDS control societies. And then we also had a mechanism for NACO when it was created in 1992. In fact, it is a unique model. That's why governance is so important, I say. It is a part of government. An additional secretary is posted as a project director. It gets its budget from the government. But at the same time, it has some autonomous powers in the sense that even though he is an additional secretary, this gentleman has all the powers of a secretary. So he could take independent decisions, including finance. And there is a separate board, National AIDS Control Board, again headed by the health secretary, which had a representative of the finance ministry in that. So that board had the power of an entire finance ministry given to them, delegated to them. They could create positions, they could authorize expenditure, they could approve budgets, all those things were done. So we went to that NACB, the National AIDS Control Board, and overnight we could create about 700 positions to sort of to see that all these 28 and odd AIDS control societies are adequately, supported with people. So that was done. Then the program started moving forward. The other important component of this is involvement of civil society. Because this program would not have succeeded but for the involvement of the communities who are most affected. Because Sentinel survey, what we conducted, brought out not only the total estimate, but in which sections of the population the HIV is more prevalent. And we found that in the sex workers, 55% of the sex workers population in Mumbai were actually HIV positive. So that means essentially it was a heterogeneous epidemic going through the sexual route from sex worker to the client and also the other way. Second is certain small percentage among drug users, especially in the northeast we had. And the gay population, MSM, and also transgender population. At that time that was not very well understood. We never thought that was important, but later on we found yes. So we identified the sections of population who are actually most affected. So how do we involve them? No, they live absolutely without any access to any healthcare services, and highly stigmatized population. When you go, even they refuse to get photographed. Even they don't even want to talk to you. So ultimately, we thought unless we create capacity within them, empower them, and see that they form their own groups, we will not be able to access them. So we proactively gave them some funds, gave them some space also, and created what we call targeted intervention programs. That means a group of sex workers, about 500 to 1,000 of them, can get together, and we give funding to them directly from the program, through the state society, and they have their own interventions. And what should be those interventions? For example, they should have some office space to have some management. They should be able to distribute condoms to the people. There should be something like an interactive information, education, communication campaign. And also we gave money for enabling environment. Because sex workers are stigmatized and they are also criminalized under the act. So the police are constantly after them. So unless we sensitize the police, they will not allow these people to function. They will not allow them to distribute condoms. So we also gave a certain amount of money for them to sensitize the local police, the constables and the officer in charge of the police station, etc. This is how this program was built. And nobody was there to tell us how to do it. We ourselves sat with experts, some of our own people, and said, okay, these are the 4 or 5 things that need to happen. So that was put. And slowly we decentralized the program. And that the first time, what now people call social contracting, that means directly giving funds to a community-based organization, started in NACO.
Okay.
No other government agency was giving funds directly to a community organization before that. But we are the first to do it.
Okay.
So that's how money flowed in to them. And within a period of 3-4 years, when we conducted again another sentinel survey similar to this, we found that the number has markedly come down. The percentage of infections among those populations, especially among sex workers, which was the most important, it came down. So that means you have 2 or 3 things. One is you have the data, you have the political leadership, you have the finances coming in. Because when they saw that India came out of denial, the World Bank also, which was the funding agency, they said we are willing to fund.
Right.
Before that, they were actually thinking of withdrawing. But when we said, yes, we have accepted it, it is a big problem, and the statement coming directly from the Prime Minister, so the World Bank said, okay, we will continue financing. So they have got another $200 million they have put.
Right.
Then the bilateral funding agencies like the British, the USAID, and then the European Union, the Canadians, all of them, they came. Then they wanted to give funding in different places. I said no. You have to sort of pool your resources, give it through our budget, so that we can coordinate and we can tell you where your particular agency is going to work. I mean, otherwise, it will be like a haphazard response. So they all agreed. So ultimately, we pooled all the money. So the total came to something like $600 million.
Okay.
One of the biggest disease control programs at that point of time.
Right.
And that's how the whole thing started.
Okay. What was driving you in this whole?
That's a good question. Because when I came, I was really, I was very down when I saw the souls. And said, where did we come? What can I do here? But then 2 instances. When I went to Maharashtra, I went to Kamadipura, the sex area. First time sex worker area. There were about 100,000 sex workers there. One of the biggest. The conditions in which they are staying, and then their way of life, the way they are engaging the clients, etc. It is absolutely subhuman. I mean, no human being can stay like that. That has shaken me actually. I and our health secretary also came with me. Both of us were really shaken seeing that. And when I talked to some of the sex workers themselves, I asked them, how many people do you think would have been infected? So one of them said, "Sab socho, 8 आना तो चला गया." 8 means 50%. So I thought she must be exaggerating. So 1 year later, when we conducted the sentinel surveillance, 55% were actually HIV positive. So that has really thought we must do something here. Second is I was taken on a short trip to Thailand. Because Thailand was doing some great work.
Right.
Actually, in about 3 to 4 years, they could bring down the epidemic there also. Again, using a similar approach. There also it is a sexual route mostly. So we went to one of their centers for orphans, AIDS orphans, young children. They were running a care center. So we went there and then talked to the people. See, there were no ARTs at the time. So people who have the HIV ultimately were dying. So I asked that nurse, 2-3 nurses, how long these people will live. So she said not more than 5 years. Maximum longevity among these boys and girls 5 years. So one of the girls, the nurse just brought me. So I immediately took her in my hands. That is the first time I touched a HIV positive person. And then it gave me a shock, really. I mean, this small girl who is a few months old, why should she die?
Correct.
I mean, can't we do something to see that at least she can live longer than what she is? So these 2 incidents somehow, thought, no, I think I must stay on and work here.
Okay.
So somehow I think that changed my entire outlook, and since then I have been interacting with the communities. For the last 20 years I have been in different fora and otherwise. I mean, I feel that after 2 decades I am a better human being today
Mhm.
because of this particular interaction which I had.
Right.
I have some excellent human beings I met
Mhm.
among these people,
Right.
whom we don't even recognize as part of society.
Mhm.
They live on the margins.
Mhm.
But that's where I found real humanity.
Right.
See, so I think these experiences somehow has a very deep impact upon us. There were days I worked for almost 16 hours a day, and the way we used to organize meeting, I had a room this big in Nirman Bhavan. At a time, we used to have 3 meetings. One in one corner, one on my chair, one on the side.
Okay.
That's how we worked.
Mhm.
And then this team of people whom we brought were also very dedicated people.
Right.
So I think we had the right combination of
Mhm.
people. And also the type of media exposure that HIV got because of the Prime Minister's statement,
Mhm.
that has motivated everyone.
Right.
It's really something.
Mhm.
And also some of the reports coming in about large number of deaths happening in the rural area, very
Right.
silently people dying, etc.
Mhm.
I think that has stirred the imagination of
Right.
everyone. So
Okay.
we had the right combination of everything.
Everything. Right.
Opposition not to the program, but then the type of financing we got from World Bank, etc. There were always people who they thought, look, NACO has been sold out to the external donors,
Oh.
so they just manufactured this number of 3 million to attract more more money from outside.
Mhm.
So that's the type of criticism which was coming.
Mhm. Okay.
And also because we were working with sex workers, interestingly, there were a group of people who are again women organizations
Mhm.
who were opposing it.
Okay.
They said, look, NACO is working with sex workers, ultimately they would like to legalize sex trade in the
Okay.
country. So it should be stopped.
Okay.
So they all went to the Prime Minister and gave him a big representation
Mhm.
saying that this sex worker interventions must stop. We had to give a convincing reply. Again, because of the person who was there,
Mhm.
he quietly ignored it. He
Okay.
didn't give much of
Right.
But these are the type of
Right.
criticisms which are coming through.
Mhm.
So about the data especially. Said,
Mhm.
how did you know the 3 million people?
People. Mhm.
So we said, how do you not know?
Mhm.
I mean, come on, give me a counter.
Yes. Give me
See,
other.
we have done it over the scientific system.
Mhm.
We have collected the blood samples,
Mhm.
analyzed them,
Mhm.
used a mathematical model,
Mhm.
and then came to this number. And this number has been accepted by the UN.
Right.
See, the advantage was because we were doing our own data collection and analysis,
Mhm.
even the UNAIDS, the
Mhm.
joint program, they were publishing their own figures.
Mhm.
They were publishing India would have 4 to 6 million.
Okay.
We said, where did you get this?
Mhm.
They said, some small sample we have taken.
Mhm.
I have given a bigger sample.
Mhm.
It is a nationwide sample.
Mhm.
And I am getting this number, so you come down and work with me.
Mhm.
So ultimately they accepted.
Okay.
They accepted our number.
Hmm.
Since that time, in the last 20 years, UNAIDS never questioned India's data. Basically, not only in HIV, in many areas, we don't give adequate importance to data and evidence.
Mhm.
And when somebody comes with their own evidence and some conclusion, we only brazen it out. Say that we refuse.
Mhm.
We ignore. We don't accept.
Mhm.
But what is your data?
Mhm.
So you need to come with a counter from
Right.
your own side.
Right.
So if you are strong on your data,
Mhm.
and if you publish those data in an open way and not conceal it in your files,
Mhm.
then I think it will lead to a much more open and transparent
Right.
system. Initially, it was a completely unknown disease.
Correct.
See, so you need a lot of technical advice
Mhm.
to the physicians, to the nurses,
Mhm.
to people working on that, to everyone.
Mhm.
You know, how programs should be organized, how treatment should be given,
Mhm.
how infection control measures have to be adopted. So a lot of technical guidelines
Okay.
had to be issued.
Right.
That's where I think the WHO has helped us a lot.
Okay.
They brought a team of experts,
Mhm.
and then who are working with our own experts within the country,
Right.
as you said, from medical colleges, from AIMS,
Mhm.
etc.
Mhm.
They trained them.
Mhm.
And then, in fact, for every district hospital, they have trained one particular physician. It's called Physician Responsible for AIDS Management.
Mhm.
PRAM, they call it.
Right.
Physician Responsible for AIDS Management.
Mhm.
So in all the 600 districts, you had 600 doctors who have
Okay.
been trained initially.
Okay.
Then they have trained the others. So we went through an organized system of training and capacity building in the hospitals.
In the management
in the
of HIV.
management,
Right.
including teaching hospitals,
Okay.
medical colleges,
Okay.
etc. Initial stage we had to do. But of course, the healthcare we had to.
Hmm.
They are very strongly involved. But again, the challenge we faced with the community of healthcare providers, they were also afraid of
Mhm.
HIV.
Mhm.
Many of them were not accepting patients.
Right.
Even in AIMS,
Mhm.
they were not accepting patients initially.
Mhm.
And when they accepted, they put them in separate AIDS wards.
Correct.
That led to greater discrimination. So we told them right in the beginning there should be no AIDS wards. They should be treated in the general ward. Only thing is, you see that proper infection control measures are adopted. You wear a mask when you go to them, wear gloves if you want to operate, etc. But then still that, mental block, that I am dealing with an unknown disease, how do I do that? You have to overcome that. So, but the first case was always the most important. When there's one simple example I will give you. In Safdarjung hospital, we admitted one patient who had a fracture. It's just a normal fracture. So the orthopedician said, I will operate. Then they tested his blood. He was HIV positive. So they won't operate him. They are just keeping him in the bed days together. So the wards, they came to me. I said, our people, look, the doctor is not operating because he is scared. Ultimately, I said, let's not go through the proper channel and all that. I picked up the phone and talked to the doctor. Doctor, what's your problem? He said, sir, first time I never operated a patient. I have to make adequate precautions. He said, do that. If you want to have 2 gloves, wear that double glove, put double mask, but please, for heaven's sake, operate on him. So when they get a call from me, he said, I have to do it. So he operated. And after all, it's a simple operation, and they were discharged. A couple of years later, I met this gentleman. He retired by the time. He told me, sir, what you told me at that time, after that I performed hundreds of operations on AIDS. I said, no sir, it's basically a question of attitudinal problem, mental block. And the same time, personal element is very important.
Yes.
You have to bring the personal element. Otherwise, ultimately it is people who make the process.
Correct.
See, policy cannot be just an impersonal document. You need people to implement it, take it forward. And we had that band of people, and not only in central government but also at the state level. We had very extremely dedicated band of state project directors who really took the program. That was absolutely CIPLA's own decision because when they found that internationally the prices were ruling at about $10,000 to $12,000 per month, something like that. So, and then the Global Fund for HIV, TB, malaria was established at that time. So, a lot of money was coming through the Global Fund. But if suppose you have to buy drugs at that particular price, then it would not have been effective. So, Dr. Ahmed, who is the MD of CIPLA, he is a great champion of generics. He thought generics have to be marketed. And he found this is a good opportunity for India to make a dent in this, because he's seeing a huge market at the time. Because the entire Africa was depending upon these drugs at the time. So he suddenly made an announcement, I am slashing down the price to $300 to $400 a month. So everybody thought that this man is just talking shop. But ultimately he did that. He did that, but then the pharmaceutical people, they all said he is a pirate and he is unnecessarily, taking the business away from them. But then the UN absolutely was happy. There's some alternative coming in. But after he done it, there are a number of other pharmaceutical companies also in India, in Hyderabad and other places, who started manufacturing the drugs. So when we started our ART program, that was about 2003. So we could negotiate the price in these 4 or 5 manufacturing firms in India, and they gave a very reasonable rate for us. The policy is important. The data is important, information is important, but ultimately the people are important.
For implementing.
You need to have that leadership. The leadership at the political level, drive the policy, leadership at the administrative level, leadership at the community level, and also at the implementation level. Ultimately, leadership is really important in a social sector program. These programs have not been given that priority. In the government itself. See, the TB program is equally a very important program. Even today, you don't find TB having the type of dispensation that NACO has. It is just one small organ of the Director General Health Services. There is one gentleman who heads that. And then done in a very, and it's a more a biomedical approach. The very biomedical approach. See, here we could come out of the biomedical approach. That is the biggest difference compared to other health programs. We came out of the biomedical approach. We took a community-based approach. And biomedical just is one part of it. Otherwise, prevention is where we spent a lot of money. If you look at the NACO budget at the time, 26% of the total budget went into prevention. And another 20% went into cleaning up the blood safety. Right.
Yes.
So that means about 46% of the money went for preventing the infection. The rest of it for care. So that is the type of I think proportion
Right.
we need to keep in other diseases also.
Right.
In TB also, you need to spend a lot more money on health promotion, making people aware of it, conduct surveillance, and also if there is one TB infection, how do you protect the others?
Correct.
See, those are the areas which are still not being adequately addressed.
Right.
Sorry.
Thank you very much, sir.
Thank you.